Good evening, friends. Welcome to the most important MCQs, most important topics session for the upcoming INI-CET November 2024 exam. I am Dr. Himani Joshi, your original guru for oral and maxillofacial surgery. And in this session, I'm going to discuss what is the most important few topics that you can't leave when you are preparing for your INI-CET exam. Alright, so just wait for half a minute for your friends to join in, and it's a live session here on YouTube, so anything and everything which you wish to ask, you can ask here in this session. Good evening Adya, Shraddha, Joy Boy, Jerin. Good evening everyone. Whatever doubts, whatever communication you want to do with me, you can do it on the live chat in the YouTube session, and yeah, so that's there. So let's begin. First of all, when we prepare for INI-CET, alright, see, oral surgery, we have broadly divided it into 10 topics, alright. And when we talk about INI-CET, there are 4 topics which you absolutely have to know. And if you know these 4 topics, your oral surgery score will be just complete, alright. I will just list out those 4 things. First one is exodontia, local anesthesia. Now, a lot of local anesthesia we have read in pharmacology also. We are talking about the surgical aspects of LA, which is the techniques and all of that. Third is trauma, and fourth is temporomandibular joint. Okay, these are the 4 topics. Good evening, Shivam. These are the 4 topics which, if you read for AIMS exam or for INI-CET exam, you will be scoring more than 70 to 80% marks in oral surgery. Alright. Now, out of these 4 topics, I will take them in detail also, but just to let you know, out of these 4 topics, these 2 are completely factual. What is the meaning of factual? Means very few concepts are there. Most of the questions are fact based, like what is the complication, how will you manage it, what is the technique. In local anesthesia, they will give you an image of inferior alveolar nerve block, or maybe a Cryer's elevator or a crossbar elevator, and they will expect you to know the principle. So most of the questions in exodontia and LA are factual questions. And remember, factual questions means you just need revision of the PYQs, and they are 100% scoring questions. If you know the factual questions well, you can score very, very nicely in topics like exodontia and LA. Also, I consider them as very, very easy topics. Why? Because you have been reading about LA and exodontia from your 3rd year BDS. Okay, from 3rd year, final year, internship and post-intern. So almost 4 years you are reading these topics. So there cannot be a single NEET exam or a single INI exam where these topics are not asked. What happens is, we give all the importance to orthognathic surgery, to distraction osteogenesis, because we think that they are difficult topics. Yes, they are difficult topics, and few questions will be from these difficult topics. Most of the easy questions, most of the scoring questions will be from exodontia and LA. So first, make these basic topics strong. Read about exo, read about LA the best way you can. Okay. Next we come to trauma. So Shivam, what you are asking me is a general question, not about oral surgery. It's about preparation. I will answer this at the end. Trauma. Now trauma, few topics are classical. Classical means they have always been asked. Alright. And few topics are, what you call as the recent favorites. So as the trend changes, the examiner also, sometimes he is asking you the basics, the classical things like classifications, tests, diagnoses. But as the time goes by, there are newer advancements in treatment. Earlier we used to use compression osteogenesis by compression plates. Then came the Champy's mini plates. Then came the reconstruction plate, which we are most often using it. Then comes the locking versus non-locking. So these are the recent favorites. Something which is currently going on. So in trauma and TMJ, these both topics, there will be some questions which will be classical, which you will get from the PYQs. That means they have been asked over ages, classifications, clinical features, which side there will be deviation, what is the radiographic picture of unilateral ankylosis versus bilateral. So these are classical questions. Whereas the recent advancements, any new type of plate, any newer technique, any new instruments, these become the recent favorite. Alright, so one by one we will know. So classical ones again are your scoring ones. Okay, so factual questions and classical questions. These are the questions which are the maximum scoring. And how will you score? Just by doing the PYQs. The previous year questions, and not just the previous questions but the previous year topics. If you read this, only this, then also you will be able to answer most of the questions in INI-CET from oral surgery. Alright, the recent favorite topics will be there in the recent PYQs, or it is based on your clinical judgment, because a lot of questions are clinical based. Okay, so let's see them one by one. Individually talking about each thing. Okay, I will put exodontia in the classical favorites. In exodontia, you have to remember the image based questions. Like I said, crossbar elevator, they will give you an elevator and they may ask you the principle or the name. Okay, so instruments based, image based questions. That's classical favorite. Okay, next comes the transalveolar extractions. That means the third molar extraction. Then in third molar also, in the transalveolar extractions also, canine and upper 8 are not so important. Lower third molar is the most important. So impactions are transalveolar extractions. So everything about transalveolar extractions is very, very important. Incision, what is the type of incision? What are the designs of incision? What is the complication that can happen with an anterior releasing versus a posterior releasing? So all the things, complications, everything in transalveolar extractions, difficulty level, everything in transalveolar extractions is very, very important. Next we come to the complications. Mainly your oroantral fistula, oroantral communication, the intraoperative complications like syncope and dry socket. Complications of exodontia is another favorite of the examiners, and you have to know about them thoroughly. Okay, what are the causes of these complications? What are the preventive measures that you can take? And what are the treatment options available? So that is the next thing. And the last thing in exodontia I would want to say is the medical history of the patient. Lot of questions do come on the medical history. For example, if a patient is on chronic long-term steroids, how will you manage that patient? If a patient is taking blood thinners, now whether it is aspirin or it is heparin or warfarin, so what kind of blood thinner? Patient has asthma, patient is on antiplatelet therapy, PT, INR, APTT. So medical history based questions are very, very important in exodontia. Let us quickly go through some of the things, like for example, these principles of elevator and what is the mechanical advantage they offer. Okay, less commonly the mechanical advantage, more commonly the image based and the principle. The image of the elevator and the principle. This becomes really important. It is easy. Please don't make mistake in these type of questions. You might make a difficult distraction question correct, but these questions, these are the most scoring. So please don't make mistakes in these questions. Alright, I will just finish my presentation and then I will take one by one all your doubts here. Next, difficulty assessment. Now see, there are a lot of difficulty indices. Warfay, Pedersen, Peterson, Parent Scale and 20 others. What is most important and most clinically relevant is the Pedersen difficulty score. Okay, maximum you can read a Parent Scale also. But all the others, just a full form is enough. You don't need anything else. One question which is numerical based will definitely be there in oral surgery. If it is there, it will either be from LA or from the calculation of the difficulty score. So this table is very, very important. You have to know what is the Winters classification, what is the classification based on depth, what is the classification based on the Ramus relationship, and how to give them the score and how to add the score and give the difficulty index. So it can be an OPG based question where the impacted tooth is given to you, or it can be a simple question where they give you that it's a mesoangular level B and position C, something like that, class C. So you have to calculate the score. So that is another very, very important. Incisions, so envelope flap, triangular flap, trapezoidal flap, these are the common basic designs. And when you give it in the third molar region, what can be affected? So when you are giving that anterior releasing incision, so if you give your incision here, the anterior releasing incision, it can damage the buccal artery. Posterior releasing incision, if not given correctly, can damage the lingual nerve. What is the position of lingual nerve in relation to the alveolar crest in the third molar region? So everything around the third molar in the mandible is very, very important. We have discussed all of this in great detail in the live class also, in the recorded classes also. So you can go back and watch these if your concepts are not clear. Certain techniques which are also asked as image-based questions. The lateral trephination technique by Boulder Henry, which says that remove the partially erupted mandibular third molar, or partially developed. Not partially erupted, partially developed means only in the crown stage you can remove the third molar prophylactically through the lateral approach. So this is one technique. Lingual split is another examiner's favorite. They have given this particular image from Kruger's so many times and they have asked you just the name of the technique. So this is given by Sir William Kelsey Fry, the lingual split technique. Okay, use the chisel and mallet just to fracture the lingual cortical plate and withdraw the whole tooth completely. Next we come to complications, dislodgement of tooth into the maxillary sinus, as it can be given in the OPG, it can be given in the CT, or dislodgement into the infratemporal fossa, dislodgement of tooth into the sublingual pouch, like it is seen here in this axial CT. You can see the dislodgement of tooth into the lingual pouch. Why? Because when the fracture happens below the level of the mylohyoid, the tooth can easily split. And why the fracture will happen? Because the lingual cortex is really, really thin. So if you use your elevator in a wrong way and you push the tooth instead of pulling it out, you can fracture that thin lingual cortex below the mylohyoid and the tooth can be displaced into the lingual pouch. So these complications are very, very important. Dry socket is an all-time favorite. Starting from the Burns hypothesis, what causes the dry socket? What are the causes? What are the symptoms? Lot of questions asked on symptoms, that pain, foul smell, development of the symptoms on the 3rd to 5th day. Okay, and management. No antibiotics, just analgesics and obtundent dressing. So very, very important is dry socket. Oroantral communication and oroantral fistula. So just definition, when do you call it a communication and when do you call it a fistula? Immediate management of a communication. Tests to diagnose. So water holding test is the absolute objective test, not dependent on the patient, but you can do that and you can see that the water is coming out from the nose or not. So water holding test, which is the most important objective test, and the delayed management, that is the management of oroantral fistula. So once there is a fistula is developed, you have to first manage the sinusitis, which is caused by the fistula, by treating the sinus, giving a sinus regimen, putting a palatal splint and separating the oral and sinus nasal cavities, and then managing the communication, managing the fistula by excising the fistula and closing it with the flap. So just the flaps are not enough. You have to treat it either in an immediate manner, which is a communication treatment, or in a delayed manner if it is a fistula. So the whole concept of OAC and OAF should be clear. Okay. Next we come to exodontia. So now this finishes about our LA. Now we come to, this finishes exodontia. Now we come to LA. Again, LA I will like to put it in the classical favorite categories. Local anesthesia. In local anesthesia, image-based questions on techniques. You know that they will give you an image of greater palatine nerve block or infraorbital nerve block or inferior alveolar nerve block, which muscle it is piercing, which space is the needle going into, or Go-Gates mandibular nerve block, Vazirani Akinosi closed mouth mandibular nerve block. So image-based questions on the techniques is the classical favorite. Next we come to the individual drugs. Lot of questions on individual drugs and their properties. Like what is the pKa, what is the onset of action, what is the duration of action, what is the advantage with ADR, without ADR, what is the contents of the LA bottle. So drugs and their properties is the next most important. And third can be asked are the numerical based questions. Numerical based questions on LA are mostly asked in NEET but can also be asked in INI. So these are the classical favorites. Let's quickly see about the properties of LA. I've always told you don't mug up the properties, just remember this diagram. If you remember this diagram, you will be able to answer all the properties of LA in one go. Alright, so this is a nerve membrane. Like any cell membrane, it's a bilipid layer. Okay, so if your drug is lipid soluble, that is it dissolves in the lipid very easily. That means it will easily cross this lipid membrane and have a quicker onset of action. Alright, so lipid solubility directly related to anesthetic potency. The more is the lipid solubility, the faster it will go, and the less dose, in less dose only, it will be more effective. Similarly, these are the proteins in the bilipid membrane. There are some extrinsic proteins, some intrinsic proteins, and if your drug is highly protein bound, if it has high protein binding ability, that means the drug will bind to this protein and will stay there for a long duration because it is highly protein bound. It has affinity to bind to the proteins. So your duration of action drug will be longer because it is coming to the membrane and it is going and binding to the proteins of the lipid membrane. Alright, so high protein binding, more is the duration of action. Just like that, we've discussed all the properties of LA in detail and questions can arise from all these properties. Next we come to the other uses of lignocaine. We know lignocaine is used most commonly as a local anesthetic agent. Other than that, it is used for ventricular tachyarrhythmias. Okay, very favorite of examiners. Which tachyarrhythmias? You have to know the list. How is it used? It is used directly IV. 2% lignocaine, obviously without adrenaline. It is available for a direct IV push in management of ventricular arrhythmias, mainly the tachyarrhythmias. Another agent like reversal of LA effect, phentolamine mesylate is examiner's favorite. Bilipid or intralipid solution for reversal of toxicity. All these factual questions from LA will be the high scoring topics. Like I said, image based questions can be asked on techniques. So you have to know when it is called infraorbital, which is something like this, an MSA or an infraorbital, or when it is called a PSA, where it is called an inferior alveolar. You know that the pterygomandibular raphe is pierced, which is made up of the buccinator and superior constrictor. Remember, medial pterygoid is not pierced in IANB. Okay, what you really pierce is the pterygomandibular raphe. You are medial to the, or you are lateral to the medial pterygoid. So this is your medial pterygoid muscle. This is your ramus of mandible. And in between that, there is a pterygomandibular space. And in that space, in that potential space, you're actually injecting your LA. So all these questions on the techniques of LA are very, very important. Next we come to the complications of LA. Intraoperative complications like syncope. What is the immediate management of syncope? Do you have to stop the procedure? What can you do to prevent a syncope? All these things are important. Okay. And like I said, the next most important thing is the medical history. Okay. In medical history, you know when a patient is taking a blood thinner, what you have to do. If you don't know, go back to the videos. We have discussed in great detail what are the two types of blood thinners. Like if I have to tell you, the two types of blood thinners, like the drugs which are given after a cardiovascular accident like a MI, or after a cerebrovascular accident like a stroke or a TIA, the neurologist or the cardiologist prescribes blood thinners. Blood thinners are of two types. They can be antiplatelet drugs or they can be anticoagulants. And your management will depend on whether the patient is on antiplatelet therapy or on anticoagulant therapy. In that also, your management will depend on whether you are doing a minor oral surgery or whether you are doing a major oral surgery. So a lot of factors decide which antiplatelet drug has to be stopped, in what kind of surgery they need to be stopped, when you can continue with the same therapy, when you need to do the bridging therapy. So all these concepts are very, very important for INI. Bridging therapy we have discussed in great detail. When a patient is on warfarin, which has a long half-life, you bridge the patient to heparin, which has a very short half-life of 10 to 12 hours, low molecular weight heparins. Admit the patient, start subcutaneous heparin, bring the PT INR of the patient down. A patient who's on warfarin will have a high PT. Everything can be asked from this topic. And you bridge the patient to heparin so that INR comes down, your PT comes down. APTT will rise, but then you can stop heparin 1 day prior to extraction and do it in a normal PT and APTT range. So blood thinners are very, very important. Similarly, steroids. When do you have to double the steroids? When you have to increase the steroids? We have discussed this table in great detail. Routine dentistry. What is routine dentistry? Okay, all the RCTs, all the fillings, all the periodontal procedures and even grade 3 extractions come under routine dentistry. So in that case, you have to do no dose modification in your treatment. But when it comes to minor surgeries, like if you are doing a cyst enucleation or a small mucocele resection, or if the patient is really, really apprehensive, you can give a equivalent dose of 25 mg hydrocortisone. So remember, cortisol or hydrocortisone is the standard. Okay, and based on that, there are equivalent doses. So you know that hydrocortisone 20 mg. Instead of that, you can give all these drugs in these doses. If you want to give a long-acting drug before your surgery, you can give a dexamethasone, okay, or a betamethasone. Mostly we use IV dexamethasone. Pre-operatively and post-operatively, you can give prednisolone, like Vizolone or methylprednisolone, something like that. So you have to remember these dose equivalents, and you have to remember what kind of surgery will need how much dose modification. And remember, all this is only required in primary adrenal insufficiencies, not in the secondary insufficiencies. Okay. So this completes our list of local anesthesia topics. Next we come to the third most important topic in oral surgery, which is trauma. Now in trauma, I would like to place certain things in the classical favorites first. So, classification of fractures. Basic classification of all the fractures. Simple fracture, compound fracture, comminuted fracture, pathological fracture, atrophic mandibular fracture. Very, very important. Anything and everything from classification is asked very, very subtly. It will look like a very easy and a very simple questions, but you will make mistake here. So classification, basic classification of fractures, very, very important. Next we come to image-based questions on wiring. Although wiring is used very less nowadays, but still image-based questions on wiring are still asked. Similarly, image-based questions on your instruments. Instruments like Rose maxillary disimpaction forceps, Gillies temporal approach, Rose zygoma elevator, or a Bristow's elevator, or the Hayton-Williams forceps. So instrument-based, image-based questions. Third, rarely asked are the most common wala. Most common fracture of the face, nasal fracture. Second most common fracture of the face, mandible. Most common fracture of mandible, condyle. So most common wale questions also sometimes they may ask. Next we come to the basics of armamentarium. And this is difficult. Here you have to know the concepts. Till now these are all factual. Factual. Just remember the facts and you will score. Armamentarium is not factual. It is conceptual. When to use mini plates. When to use compression system or lag screw. When to use the recon plate. What is the advantage of locking versus non-locking. When to use a rigid fixation. When to use a load-bearing fixation. So concepts based on the armamentarium are another classical favorites. Sometimes they will ask you, SR level questions just from the armamentarium. So just do the PYQs very nicely. Read the explanations in the app. Beautiful explanations are given. Just if you read the explanations nicely, you will be able to understand the concepts. Still, if you are in doubt, you can go back to the videos and recorded lectures and you can see. The concepts here are very important. And in classification also, condyle is very important, especially pediatric condyle. So treatment will be dependent on classification. Okay. Next in trauma, just check my list. Yeah, so I have not missed anything. Next in trauma are the recent favorites. Here is the difficult part. Now recent favorites are mostly those topics which you are not taught or not seen in BDS. Mostly you have seen all these things in your BDS curriculum. You've seen them, you've read about them, you've written your answers. But the recent favorite topics are some topics which are the examiner's favorite, which usually we do not see. Here in trauma, orbit. Very important. Okay, anatomy of orbit, terminologies. Okay, like what is anterior chamber, what is posterior chamber, what is what is iris, what is pupil, what is sclera, what is hyphema, what is subconjunctival ecchymosis, what is panda faces, what is raccoon faces, what is circumorbital ecchymosis. All these terminologies related to orbit are very important. Next in orbit is the concept of TCR or OCR. Okay, I've taught this in the miscellaneous part. The trigeminal cardiac reflex, which is very commonly seen in blowout fractures, mostly the trapdoor fractures, which are also called the white eye syndrome. So TCR and OCR is the current favorite of the examiners. Lot of questions have been asked directly, indirectly, holding the question from here. Very twisted and turned. But if you know the concept of what is oculocardiac reflex, why it causes a problem, why it causes a hypotension, why it causes bradycardia, why it is seen in blowout fractures, which muscle is entrapped, why it causes a restriction of gaze. So all the tests related to orbital fracture. This is the current favorite. Okay, so please understand orbital anatomy very nicely. Another such topic is naso-orbito-ethmoidal region. Here also, what is the importance of medial canthal tendon? What is the bowstring test? What is transnasal canthopaxy? So these are the current recent favorite of examiners because they are bored of asking the same classical questions. So maybe one exam they will ask the classical questions, next exam they will directly jump onto orbit and NUI. Alright, and such difficult topics they will ask. But again, don't worry, these are all again scoring if you know the concepts. If these are factual, then these are conceptual. Factual you can understand with PYQs. Conceptual you can understand with the videos. So once you are done, once you are thorough with your factual topics, read the conceptual topics, understand the conceptual topics. That will take you from a rank of 2000 to 20. Okay, that is where the difference in ranks come in. All right. So quickly showing you certain topics in trauma. So this is a closed fracture of condyle because it is not involving the skin, it is not involving the oral cavity. But this is an open fracture because in spite of the fact that there is no laceration, but the fracture is communicating with the periodontal ligament. So they will call it a compound fracture or an open fracture. So simple classification based questions. Comminuted fracture, very common and very important MCQ, pathological fracture. A fracture which is caused due to a pathology. In this case, it can be osteomyelitis, it can be carcinoma, malignancy. So here the treatment of fracture is not important. Here the diagnosis of pathology becomes more important. So your first step will be biopsy. So treatment based on the classification of fracture is very important. Next comes to clinical decision making. I'll give you a very simple example. If there is a fracture in the symphysis of mandible, okay, and the question is, which is the simple, it's an undisplaced, linear, minute hairline fracture. If these are the words, simple, undisplaced, occlusion is intact, what is the simplest treatment? You can even do a residence wiring here. If it's a child, undisplaced fracture, minimal or no occlusal disturbance, or if it is an adult, the minimal intervention that you can do is a 4 to 6 weeks of IMF. Then if ORIF you have to do, what is the simplest or the easiest treatment in ORIF? 2 mini plates or 2 lag screws or 1 mini plate, 1 lag screw. So question is same. Now depending on what the examiner is asking, how he is deciding or how he is designing the question, that will decide your answer. So there are so many treatments for a symphyseal fracture. There are 6 treatments. You can do an IMF, you can do mini plates, you can do lag screw, you can do 1 lag, 1 mini plate. You can use a compression plate with a tension band. Tension band can be arch bar, tension band can be the mini plate, tension band can be a lag screw, or you can use a recon plate. So depending on the language of the question, you have to make a clinical decision of what is the, sometimes they will ask you the best treatment. So that will depend on the age of the patient, on the buying capacity of the patient, on the dentition status, on the favorability and unfavorability of fracture. So all the concepts we have discussed in the trauma videos, and you have to make a decision based on the language of the question. So first you should know what are the treatment options. Okay, if it's a single fracture, you'll go for a mini plate. But if the examiner asks that there's a symphysis with an ipsilateral or a right side or a single angle fracture, suddenly this option goes away. Suddenly you are only left with either, a recon plate here and a mini plate here, or a full recon plate or something like that. So language of the question will decide the treatment options. When Champy's principles are applied, when Champy's principles are not applied, everything will depend on the question's language. So know the treatment options and choose the option accordingly. Lot of questions, simple image based questions on the Leafort lines have been asked. So you have to know the Leafort lines. Treatment is very easy. Put 4 plates, L-shaped mini plates. Instrument based questions, this is the Rose maxillary disimpaction forceps, this is the Hayton-Williams forceps. Where do you use it? How do you use it? And Noe and orbital fractures. Lot of questions are also asked on normal distances. What is the normal intercanthal distance? What is the normal interpupillary distance? Is it equal to the width of ala? And all those questions, okay? And the MCT based questions. We've discussed this in great detail in the videos. MCT or the middle canthal tendon, nasolacrimal duct. These are those few very difficult questions that can, take you from a lower rank to a higher rank. So when you are, again, remember, out of 14 questions in oral surgery, 10 will be easy, simple scoring factual questions. First focus on this. If you do the 4 difficult ones okay and your easy ones are wrong, there is no advantage of doing the difficult ones correct. First, make sure that the 10 easy questions, which are simple, factual, repeat, PYQs, they should be correct. Then focus on the 4 very difficult questions. Okay? If you are doing your easy PYQs wrong, you are out of the race. You are not in the race only. Only when you have done these correct, you are in the race of the top ranker. So first come to the race, first come to the track. Then think of a top rank. Alright? So these are difficult topics. You have to know the concepts for answering these questions. And we have discussed them in great detail. Like the bowstring test. Lot of image-based questions are asked on bowstring test. You should know it. Okay? Force duction test. What will you do when the patient is conscious? What will you do when the patient is under GA or when the patient is unconscious? Okay, so you will do a force duction test in an unconscious patient. You will do a gaze test where you check the 9 gazes or the movements of the eyeball in a conscious patient. So depending on that, you will have to answer here. And the 4th most important topic in oral surgery after trauma is TMJ. Alright, so we will take up TMJ. You can keep taking screenshots if you want to, remember the names. Okay. So the next most important, the last most important is the temporomandibular joint. Okay. In TMJ, oh, why this is cutting up? In TMJ also, there are certain classical favorites. What is the most important cause of ankylosis? Trauma. Which of these is not a theory for ankylosis? Okay, we are talking basically about ankylosis. Clinical features. Very important. Chin is deviated to this side. Adult may no clinical features. Obstructive sleep apnea. Snoring. Clinical features, very, very important. CT based questions. It will show you a unilateral or a bilateral ankylosis. You have to identify, you should be able to identify in a CT scan. What is a unilateral ankylosis? What is a bilateral? What is a condylar fracture? Okay, all the CT based questions on ankylosis and on TMJ, you have to know it. And CT based treatment options. So we know that classification will decide the treatment. If it's a Sawhney's class 1, just Brisbane forces is the treatment. If it is a Sawhney's type 2, you can do a lateral arthroplasty if you want to preserve the ramus length. If it's a type 3, type 4, you'll have to do a conventional gap arthroplasty followed by any kind of reconstruction. So classification, CT based classification, treatment option based on the classification, and certain drugs that prevent the re-ankylosis. Very important is indomethacin. We have discussed this. Very important is fat. Okay, if you put fat in the area of ankylosis, the chances of recurrence of ankylosis is less. So heterotropic bone formation is reduced with indomethacin and with autogenous fat. So you can put the temporal extension of the buccal fat pad. You can take some fat from the abdomen and put it in the gap. So fat is very, very important. This is also asked. And last classical favorite here, I will write it here, is the intubation. Lot of question will be asked on intubation in ankylosis. When will you do a tracheostomy? When will you use a fiber optic intubation? Is oral intubation an option? Which is better, a North Pole tube or a flexometallic tube? So intubation based questions we have discussed in oral surgery also. We have discussed in great detail in anesthesia also. Remember, in DBMCI MDS, we have separate videos for you, especially for anesthesia. So you can read about intubation, you can listen to intubation from anesthesia also. And I have also covered it in oral surgery. So intubation is the next most important. In the recent favorites, I will expect one question, definitely one question from internal derangement. Again here, stages, clinical features. Very rarely they will ask you management. Till now they have not asked the management, but stages and clinical features are very, very important. Multiple questions have been asked very recently from internal derangement, from the Wilkie stages, and you have to know the concept behind internal derangement of TMJ. Second is the pathologies. Lot of questions on condylar hypertrophy and idiopathic condylar resorption. So CH and ICR are another favorites because a lot of patients come to AIIMS with these problems. Okay, so these are the recent favorite of the examiners. Alright, quickly jumping on to showing you the TMJ pictures. So Sawhney's classification, treatment based on whether it is type 1, lateral arthroplasty in type 2. What is the definition of type 3, type 4? That means when the whole thing is big chunk and it is ankylosis is going up to the zygomatic arch, it is type 4. So classification, definitions, very, very important. Airway, obstructive sleep apnea. Please remember the definitions of OSA. What is apnea? What is hypopnea? What is the apnea-hypopnea index? What is the grading of OSA in an adult versus a child? So if it's a child, how much AHI would be classified as mild, how much will be moderate, how much will be severe versus a child? Remember, the grading is different for an adult and a child. So your treatment, whether you will do a mandibular distraction first or you can do a treatment of ankylosis first, will depend on the grade of OSA, will depend on the apnea-hypopnea index. So OSA is very, very important. We have discussed this in great detail that when you treat a patient of TMJ ankylosis, his airway worsens. There is worsening of airway. Why? First, because of edema in the airway. Second, because when the patient opens the jaw, you can see that everything goes posteriorly, everything goes back. So if this patient is normal like this, when he opens the mouth, when this patient opens the mouth, there is a slight airway restriction. But a patient who already has such a narrow airway and you open his mouth by treating the TMJ ankylosis, imagine where this mandible will go and imagine what will happen to the airway. So worsening of airway happens in treatment when you open the mouth in a patient of TMJ ankylosis. So if a patient of TMJ ankylosis also has OSA, because you will have the clinical features of snoring, daytime somnolence, sleepiness, lethargy, or in later stages the cardiac changes like pulmonary hypertension and all those things. So if he has OSA, remember the priority becomes airway. So depending on the grade of OSA, you will decide whether to treat ankylosis first or whether to treat the airway first, or whether you can do both together. So here is where distraction and management of ankylosis happens hand in hand. So please understand the concepts of airway in TMJ also. Intubation, I've showed you very nice pictures and videos of the fiber optic intubation, which is the gold standard in TMJ ankylosis. So the method of putting a tube is fiber optic intubation. This is the method, okay, with which you can put the tube. Now, which tube is the best? The nasal RAE, or the nasal preformed tube, also known as the North Pole tube. Also known as the preformed tube. Okay, so the nasal preformed, the nasal RAE, also known as the North Pole tube, is the best tube for TMJ ankylosis cases, because you have to turn the head again and again. If it's a bilateral case, first you have to do right, then you have to do left, then you have to check the mouth opening, then you have to take a graft, put the graft or put a joint. So again and again you have to turn the patient's head from right side to left side. So in that case, if it is a normal PVC tube, it can kink and it can block the airway. So better than a normal PVC tube is a flexometallic tube, also known as an armored tube. So if you put an armored tube, it has metal rings. So even if you turn the patient's head, even if the tube is bent, it will just have a turn. It will not kink. It will not block. And even better than that, is a nasal preformed tube. It will not at all come in the way of the surgeon when he has to operate. So nasal RAE is the best. So all this, as we have discussed, you have to know. And internal derangement, like I have told you, the Wilkie stages, the concept behind internal derangement, and this table. Okay, in stage 1, what is there? Only clicking, no pain, no locking, no deviation. What are the radiographic features and what are the surgical findings? In stage 2, now the pain starts happening. So this is internal derangement with reduction. Okay, and locking, whenever locking starts happening, there is internal derangement without reduction. Okay, so depending on, and this stage 3 can be here or it can be there, but whenever there is a anterior disc displacement that does not reduce on opening, clearly it says when it does not reduce on opening, it is without reduction. So these definitions, this table is really important for INI-CET exam. Treatment, till now they have only asked about MyTech Mini Anchor. So MyTech Mini Anchor is a small screw which has the sutures attached to it. You can pull the disc back and you can fit it into the posterior region of the condyle, and you can treat your abnormally placed disc through the MyTech Mini Anchor. Okay, so this we have taught, we have discussed. Sometimes they can ask about arthrocentesis, which is not asked till now as an image based question, but now slowly they are starting to ask questions on arthrocentesis. Last time they asked about the landmarks of arthrocentesis. What is Holmerd-Helsing line? What is the solution that we use? So Ringer lactate solution we use. So basic things about arthrocentesis that we have discussed in the lectures is what you can expect. Condylar hypertrophy, condylar hyperplasia, and idiopathic condylar resorption. Again, cheerleader syndrome. Very favorite of the examiners. The technetium 99M MDP scan. How will you decide whether the patient is in active resorptive stage or in active growing stage? By the nuclear medicine scan. Another favorite of the examiner. So you have to know the examiner's language and you have to know the concepts to answer this kind of questions. So by this we complete the most important topics. Again, to revise, the most important are exodontia, local anesthesia, purely factual questions, high scoring. Trauma and TMJ, factual plus conceptual. High ranking. It will give you a much better rank if you know these topics. So these are the most important topics in oral surgery. Other topics from which questions can be asked, I will list those topics and I will give you. Orthognathic surgery, mostly they will ask about VRO, BSSO and Leafort 1, genioplasty. If you are reading about orthognathic surgery, when you have finished the most important topics, read these topics from orthognathic surgery. Distraction osteogenesis, only image based questions. Or Elizarov, they will ask you the principle. Either they will ask you the principle, what is the principle behind it, or image based questions. They will give you a distractor, a multi-vector distractor or a linear distractor, and they will ask you image based questions. So that is most important in distraction. Next is cleft. What is most important in cleft is embryology. Median nasal process, lateral nasal process, fusion of what prevents the, what doesn't fuse to cause a midline cleft lip, what doesn't fuse to cause a unilateral cleft lip. So embryology of cleft is very important. And also sometimes they will ask you classification. Okay, so if median nasal process on one side with median nasal process on other side, they don't fuse, midline cleft of upper lip. If median nasal process doesn't fuse with the maxillary process, unilateral cleft lip of one side. So like that, if palatine shells don't fuse, isolated cleft palate, cleft of secondary palate. So embryology, very important. After cleft, we have, what is left? Pathology. Okay, in pathology, terminologies are very important. What is curettage? What is enucleation? What is marsupialization? What is cauterization? What is en bloc resection? What is marginal resection? If you know the meaning of the terminologies, you will know where to use what. Usually we don't understand the meaning of these terms. You understand the meaning of these terms, you will be able to place that, okay, enucleation you can only do in a cyst. You can't do it in a tumor. If it's a benign tumor, you can do resection. Okay, if it is a vascular lesion, you can't do any of these things. You have to embolize and then resect. If it's a giant cell lesion, you can even try medical managements like calcitonin sprays or intralesional steroids. So, depending on the terminologies, definition of these terms, you will be able to answer the questions. And last is infections. Infections, you can have image-based questions. They can give you a buccal space infection, a canine space infection, some mandibular infections or Ludwig's angina. So image-based questions on infections are asked very often. So you have to know what is the difference between, cellulitis, that table which we have discussed, versus abscess. What are the features of cellulitis? What are the features of abscess? What is the Hilton's methods of IND? When will you do an IND? Don't get confused between a space infection and a vascular lesion. And osteomyelitis, osteonecrosis. Definition of osteomyelitis, treatment options in osteomyelitis, curettage, sequestrectomy, resection, decortication, saucerization. All these terminologies in osteomyelitis also comes under infection. So sometimes they will ask you a pathological fracture and which is caused by osteomyelitis, or floating teeth which can be caused by osteomyelitis. So these are the other topics which are, so 80% will be from the most important topics and 20% will be from these topics. What AIMS does is, AIMS will take one question from every topic. Okay, AIMS means INI-CET. They will take one question from exo, one question from LA, maybe two questions from trauma because it's a big topic, or one or two questions from TMJ, and few remaining questions from these topics. Okay, the probability of every topic coming in exam is always equal, but the difficulty of topics or the scoring will be much more in the most important topics. So if you have to prioritize, if you have to do first most important things and then the less important things, I will always ask you to do these four things first of all. You should be absolutely thorough in these four topics. Then only you should jump into the less important topics, which are these. Alright. So with this, we finish the most important topic discussion of oral surgery. Thank you so much. And I am ready to answer all your doubts now. You can start posting your doubts if you have. And okay, if I prepare only last 15-year questions with topics properly, is it possible to get a seat? 100% Shivam, you can. Last 15-year topics covers everything in oral surgery. When I am making my syllabus for oral surgery for teaching you guys, I am actually taking the last 10-15 years topics. It's very easy to say. It is very difficult to do. If you are doing that and you are doing it properly, you will be in the top 10. Let alone be selected, get a seat. You will be in the top 10. Alright, so if you can do the last 15 years or even the last 10-year papers with understanding, not just learn the answers. I'm not saying that you just have to learn the answer. No, you have to know the reason why this is the correct answer. So you understand that topic, it will cover everything. Okay, and this is not just for oral surgery, it's for every subject. Okay, Shivam, I hope that answers your question, beta. Which textbook to refer for OMFS? Should we do Fonseca? So Vishnu, this is a question from Vishnu. Vishnu, what stage are you in? Are you asking me for a BDS? Are you asking me for the aspirant? Or are you an oral surgery resident and you're asking me? So I will answer accordingly. And already I have taken a topic of the most important books in oral surgery. You can go to the DBMCI MDS YouTube channel and you can find that. Otherwise, depending on your state. So if you're a BDS student, Contemporary Peterson is a very good book. Laskins is an excellent book. And You may refer other books like Nilima Malik for an overall answering, but conceptual understanding, Contemporary Peterson and Laskins are excellent books. There are Kruger's and there are many other books, but these two are enough. But if you're a resident, all the topics have to be studied from different books. Okay? And if you're an aspirant, if you're preparing for MDS exam, please, for God's sake, don't study from textbook. You will not be able to finish the syllabus. You will not be able to revise. For an aspirant, please don't read textbook. You will not be able to finish. It's not a novel which you have to finish. Okay? Nasal and oral RAE. Beta, if you're giving the GTs, there are pictures. I don't think I have pictures here. But basically, the basic difference is, so if I take this, okay. So the oral RAE, it's actually very big. Will have a shape something like this. Okay. So the tube end and the connector will be in the same direction. Whereas a nasal RAE, it will be something like this, you know. The tube end and the connector will be in the opposite direction. It's very, very easily available. You can just Google nasal and oral RAEs. Based on the shape, you will be able to remember very easily. Broadly to remember, in oral RAE, the tube end and the connector are in the same direction because the tube comes out like that. So that is why it's called a south pole tube. And in nasal RAE, the tube goes like this into the body, but when it comes out of the mouth, when it comes out of the nose, it goes up towards the cranial end. So it is like this. So connector will be in this direction, tube will be in this direction. So that is the nasal RAE, also called the north pole tube. That is the basic difference between nasal and oral RAE. Okay. I hope that answers your question. DR. SR papers source. SR papers are there in the DBMCI MDS question bank. You can go there and read the SR papers. Harmandeep, that's the answer to your question. Hariharan, is it necessary to study textbook? If yes, which textbook should you follow? It is absolutely not necessary. It is not possible. It is not required to read textbook for an MDS aspirant. In this year, if you start reading textbook, you will not be able to finish the syllabus. So no textbooks for any aspirant. Wanderer, Wasmund, see. There are a lot of orthognathic surgeries. Okay. Some questions will be difficult, which will be there for you to leave. Okay. Wasmund, Wunderer, Cupar, these are all segmental osteotomies. Okay, in maxilla, instead of doing a full Lefort 1 osteotomy, you can also do instead of that, you can do a segmental osteotomy. If there is problem only in the anterior maxilla, you can do only anterior maxillary osteotomy. For anterior, that is between canine, you can extract the first premolars on both sides and that anterior segment you can move instead of doing a full Lefort 1. Now, to do that anterior segmental osteotomy, there are different techniques. Wasmund, Wunderer, Cupar. In some you take the labial approach, in some you take the palatal approach. So it is very, very too much into deep. Okay. Such questions, you should just remember the answers. Just mug up the answers. Don't try and go in too much detail because understanding these questions will take half a day or maybe 2 to 3 hours and it will waste a lot of your time. If it is the same repeat question, just mug up the answer and write in the exam. If it is a concept which is based on that question, you will never be able to answer it. It is mandatory. It is made for you to leave. The examiner is purposefully making that question very difficult because some questions have to be tough. So leave that question. Such questions, don't worry about concept understanding, that what is the difference between Wasmund and Wunderer and Cupar. Just remember the answer. Alright. So, DR, I hope that answers your question. Thank you for your comment, Harmandeep. That has made my day. Thank you so much. Okay. Nikesh Maheshwari is asking, ma'am, wiring seems confusing. Can you brief? I am sorry, Nikesh. This is not the right time to brief you because it's a concept. It will take a lot of time. In the recorded videos, you have very nice Every wiring is described in detail. What is the indication, what is the problems, everything we have discussed. You can go back to the, if you're not an enrolled student, you can take the revision plan also. In revision also, we have discussed the wiring techniques in lesser detail, but in a way that you will be able to understand. So it's little difficult because I will need images to explain, and this is not the right time to explain a concept. Okay. I had to give NEET MDS in 2026. I don't understand your question, beta. Shivam, as you have less time, so if I do only clinical subjects of last 15 years, is that enough? No, it is never enough. You cannot leave a subject. You can never leave a clinical subjects. कितने होते हैं? Clinical subjects are only 10. Out of 19, there are only 10 clinical subjects. That means you are leaving half of the syllabus. So that's never ever justified. You can attempt, but don't expect a rank if you are doing half of your syllabus for exam. Alright, I'm sorry to be rude. I'm sorry to be flat on your face, but this is the truth. If you do 50% syllabus, how can you think of being a topper? Alright, and only clinical subjects means half of the syllabus. So that will not help you. Okay. Okay, transbuccal approach for angle fracture, not able to understand. Whatever you are not able to understand, please connect with me in the doubt sessions or go back to the videos and watch it again. If you don't understand, we will have an oral surgery doubt session where I will take everything again. Okay, this is a discussion of the most important PYQs in most important topics in INI. Alright? Alright, so that answers all your questions. Thank you so much for the patient learning, the patient listening. If you still have doubts on individual questions, you can post them in the DBMCI MDS Premier Telegram group. If you're not a DBMCI student, you can still post your questions in the DBMCI Premier group, and I'll be able to solve, I'll try to help you with the answers as best as I can. All right. Thank you so much. Good night, everybody.